And also go ahead and place your name and campus in your chat. You all, this is the second week a storm has just started. So hopefully it's safe for us to proceed on. But in the event that I lose connectivity, just stay right there. I'll try to log back in once it's safe. Hopefully I don't lose connectivity, but it thundering and the lightning's kind of passed, but it is a little thunderstorm is going on outside. So we have about 20 seconds. So good evening to everyone again. We'll call it official start time here in about 20 seconds. Place your name and campus in the chat. Do we have anyone that's new here tonight that was not here on last week? Anyone new? So it is official start time. So go ahead and come on cameras. Let's make sure that we are recording. Yes, we're recording. And I would just like to remind you about, the etiquette and everything. And also, if that we're on camera and we are being recorded. And the attendance administrators, they can and will, and they do review these recordings. So just make sure that we're adhering to the guidelines. Place your name and campus in the chat. In addition to that, go ahead and check your screen name. Make sure that your first and last name is correct, how it is on the roster. We don't want it to be said that you were not here because the screen name was incorrect. So give you a minute or so to get that done. Make sure that you're on camera in the event that you have to walk away from the camera, restroom, or have to handle something. Just put a message in the chat to myself. Do not send it out to everyone. We just have to have it for record purposes is why you're not on camera. So again, good evening to everyone, and make sure you place your name and campus in the chat, and also check your screen name. And if you need to change your screen name, just let me know, and I can walk you through how to change that. It did the same thing on yesterday as last week as well. Tuesday and Wednesday, little storms popped up around this time of day. I guess today is giving away tonight. The atmosphere is maybe cooling off. I don't know, but we need the rain. But it's like I said, hopefully it won't be severe or we have to I lose connectivity or anything. So welcome to week 2. So we do have one more week together. And so, of course, this week we'll go over more content this week. We'll go over more content next week. And then at the end part of class, that was our little timer. So you should have placed your name in campus in chat and you should be ready now. You've checked your screen name and all of that. So, of course, content all this week. Now, our agenda for next week, we come in, we go over more content, review content and everything. And then we take the exam to the latter part of class and you don't return. So we push everything toward the end, that exam. And of course, while mentioning that, if you have accommodations, this is for all of your classes, please submit the official accommodation letter so that those accommodations can be provided for you. Go back to we did do an individual announcement in the announcement section that addresses accommodations and your responsibilities of getting that accommodation letter out. In the event that you think you need accommodations, that information is there as well. There's a whole process to that. So just refer back to that email. It does involve your healthcare provider, your campus dean, and some documentation. I will say that part. In the event, while we're talking about week 3, you have that exam next week. In the event that that exam needs to be proctored other than, being in the classroom setting. We went over those guidelines also for that you must have that 72-hour notice in order to get things in place and everything arranged for you. So if that's something that you so desire, there are guidelines and they are there so you can refer to them, all the different steps. All right, so let's go ahead and get started. Let me pull up our course shell here. So again, we are here this week, all of content. And I like to just go back and then move forward with the content. And we come in next week, we'll go back and we'll move forward with the content. That repetitiveness of the content, it strengthens your foundation of knowledge about the concepts altogether. Because remember, it doesn't just stop for this class. It's beyond, when you take your nursing journey and you're taking care of your patients and you're providing that best care, you're going to do that because you have that strong foundation. So yes, things that we'll talk about this week and next week, like, well, we talked about that last week. Yes, we just keep layering it on and making sure you have that good understanding. Then the other side of that is if there is a concept or something that we're talking about and you're not as strong in it or not clear about it, that's going to be at the top of your list for going back to review things. So you want to start with those topics first. Okay. So again, if I lose you, stay right there. I'm going to try to log back in. Like I said, there is a little thunderstorm in the area, but I think it's safe for me to be on this here. Okay, let me share here. We will utilize our chat while we will utilize our voices to show participation. Like I said, do your jot noting. So all those things that you're really not sure of. So let's go over here to our facilities. I'm going to share it in just a moment. See, the tab moved on me, but I see it now. Okay. So again, yes, it's this week too. It's still early on. You all, when you take that first exam, it just seems like to me that things go really, really fast after, especially for those of you that are taking more than one class, two classes, three classes, you have clinicals, and you have all of your responsibilities. Go ahead and start today, tomorrow, looking at your schedule. What can I revise? What can I delete? What can I put on pause? Because it does kind of build up on after this week right here. And so we want you to, be successful in the end. So it does take that refocusing at your whole picture, your big picture, and adjusting things as needed. So last week we looked at this content here. You had that quiz. You had a case study. Wait a minute, I'm on week 2. Hold on. This was last week, right here, mental health week 1. You had the lesson. I knew I wasn't that didn't sound correct. So you had that lesson on 4. So lesson assessment number 4. Make sure that you're going in and doing those. Every point matters, you all. Make sure that you're completing things by the due date. We do have steps in place in the event that you're going to run into completing something late. Remember what that procedure is so that you can, complete that assignment. Okay, and then here we are, week 2. Have some more concepts. We're looking at the outward, inward emotions and also violence, suicide, and substance-related disorders. You do have that case study and adaptive quiz. And like I said, next week we'll come in, review content, and then we will take the exam toward the end of class. And then week 4, no, we're not there yet. But week 4, you'll transition to whatever's next on your schedule. It might be P's and it might be OB. So that's where we're at. And that's where we're going. Okay, so let's go back and let's do some recall. Let's see where we're at and get that list out and start thinking and putting things down. Now, what I did, we want to provide individualized care plans for our clients. No matter how many patients we have, for example, that has anxiety, each one of them, we still are going to provide those individualized care plans for them, individualized interventions for them. So, and that includes like their learning style. So what I do is, I guess my learning is I'm visual, I think visual, I don't know. But what I've done is taking your slides and add, you have those slides there in your slide deck, in your model, in your canvas. All of them are just blank. So I've added pictures and things. This is the same content. So don't get bothered by the pictures and everything. I need you to focus on the content. And so when we are providing care for our clients, we want to establish those therapeutic relationships. How do we do that? So 2 people come off mute and let me hear from them. How do we establish those therapeutic relationships? Because remember, we're wanting people to give us information so we can create this individualized plan so that we can provide that best care for them, right? So how do we get them to, how do we establish that therapeutic relationship? I need to hear from two people.
Making them feel
Asking
comfortable.
them therapeutic questions, open-ended questions, I'm sorry.
Got it. Good, good. And so it's important because not only because we want to provide that individualized care plan for them, that's important because also we just want to know about our clients because it's them that's receiving the care, right? And so remember, they have to consent or refuse to care. And so we can better understand what's going on with our clients if we just establish that therapy relationship. We have to get those lines of communication open because we do that no matter their pay status, no matter their ethnicity, no matter, we're there to provide that best care for our clients. So we want to establish those therapeutic relationships. And as part of doing that, they call it being a culturally competent nurse. So that means we're thinking about and finding everything out about our clients so we can provide those individualized care. So that way they're more likely to share things with us, good, the bad, and the ugly. They're more likely to share that because they think and they know that we are there for them no matter what. And so we're not looking at, like I say, whether or not they're short, they're tall, their pay status, whether or not they have insurance or no insurance. We're really there because we do have their best interests at heart. So being culturally competent involves actively learning and respecting the different values and the things that are important to our clients. And then therefore our interventions will be more effective. Not that we're trying to convince them so that we can just let us do things for them, but no, generally, remember, they're only with us for amount of time. We're not, they're coming to the urgent care to get this treatment. If we're going into their home, even if they're at the hospital, they're only there for that amount of time. So we want to equip them with the tools, with the coping mechanisms, the not maladaptive mechanisms, but the coping mechanisms so that in the event they do get anxious, in the fact that they do feel that they're getting manic, that they'll know what to do, and so that they can be as productive as possible. So clinical judgment, the nursing process, you all critical thinking, therapeutic relationships, and individualized care. You're going to hear that all the time. So bring all those things that you learned from your other classes, bring them on over. Because these are the same people that we were taking care of as a child, or you haven't had peas yet. But these are the same people that have grown up to be adults. It's across that lifespan. And so clinical judgment requires adapting those protocols based on those patient responses, what they told us. The patient doesn't understand what anxiety is, what bipolar is. They've conveyed that to us. So we need to adjust ourselves so that the care plan includes some teaching, we can reinforce. So the care plan needs to include that because if we are coming in just doing all these things for our client, all these interventions, they don't understand, they're going to be resistant to what we're trying to do. We don't want to make assumptions. We just want to establish those therapy relationships so the patients can tell us more and we are seeking to understand and learn more about their client. Okay, so tell me about the nursing process. What's that acronym that you all remember? What's the first thing that we do? Begins with the first
Assess.
assess.
It's
You all
called
great. Add
assess.
pop.
Yes,
We're
ma'am.
still using that same information. You all come bring it on over. Assessment. We're going to gather data. So, and specifically, we're talking about the mental status exam. It's a crucial component. We have to gather information about their cognitive status, their mood, their behavior, and their thought process. It's still the nursing process. We're assessing, so we're gathering data. But of course, we're more focused on that mental status exam. Okay, it's a crucial component because it's going to determine whether or not if the cognitive function is low, the client is not oriented to person and place. It's going to be important that we do reorient that person. Part of our intervention is to reorientate them to where they're at and who they are. So again, the mental status examination is a crucial component of a comprehensive mental health assessment. Evaluating, we do all these interventions and we look and say, well, hey, is this working for this patient? Yes or no? And if it's not, we need to go back to the drawing board, maybe have another conversation, reassess, gather more information. And we kind of talked about this already. Establishing those therapeutic relationships will equal providing that an individualized care for the patient. Again, like I said, we have 10 patients with diabetes, 10 patients with anxiety, 10 patients with asthma. It doesn't matter. We still will provide that individualized care for them. Okay, so when we are assessing, it allows us to assess the patient's judgment. When we're in there talking to the clients, we're asking um, the questions. It allows us to determine what is their judgment. Why is it important that we determine the patient's judgment? You can come off mute or you can share it, excuse me, in the chat as well. Remember, we are we're participating. So give me one person on off mute and respond. And then the others put it in the chat. Why is it important that we
because
assess?
we need to understand what it is that they want to even begin to take care of them, what they're okay with, what they're comfortable with, their beliefs, all of those different things.
Okay, so let's take it a step further. So define what
See
is
what their
judgment.
goals are.
Would you say a judgment is? What is judgment? I hear
I
someone's
mean, I
off
would
mute.
say their perspective.
Their perspective about what's going on. We need to determine whether or not if this client is if they realize, because remember, what's some teaching when we give some of our SSRIs? What do we tell them to do? Be careful before operating. What do we tell them?
Be careful of operating motor vehicles or
And
heavy equipment
why is that?
because of the side effects of the medication can make you drowsy or
It
Their
can make them
judgment could be impaired.
it could make them drowsy. And so if they're driving a vehicle, what if they're drowsy, what could they potentially do?
Their response time might be off or their
It is going to
judgment
be off if they're
impaired.
sleepy. Exactly. So we need to know if they understand that, hey, we've educated, we reinforced education and it said, hey, we need to see how these medicines are going to affect you. We need to see if they're going to make you drowsy before you get behind the wheel and or if you're operating heavy machinery, if you're having to do tasks that requires alertness. We need to understand whether or not this client understands the safetyness part about that part, about the situation. So we need to know their judgment. Do they think it's okay to be drowsy and drive? Do they think it's okay to not take your medicines? Do they think it's okay to be on these medicines and not come in for your lab work so we can see that your levels of therapeutic? We want to check for the patient's ability to make sound decisions, safe decisions. So what we do is, in that instance, we give them some examples. Hey, I've just told you, I've reinforced, and we talked about these medicines that you are on. So let's say, for example, then what you say you do for work now? You say you work on I forget what you call the people that are out there doing the roles. It's a name for them, but you work on the work crew that where they're driving those big old machines and they're out there flagging people down. So you do that. So if you just start taking these medicines tomorrow, and more than likely they're going to make you sleepy, do you think you need to ask your supervisor to change up your task for the first week because these medicines might make you drowsy? So I'm just creating a situation. So that's how that conversation will go with our patients because we've established those therapeutic relationships. They told us what they do from day to day. And because of that, we realized, well, hey, this client's at risk for injury or either causing someone else injury. So we want to assess their judgment to ensure the patient's, to see what the patient's ability is to make sound judgments. Judgments is assessed by exploring how the patient would respond to real life problems or dilemmas, like the example that I just gave. And we can make up, different situations depending on what your patients tell us that, they do from day to day. So we just want to make sure the information that we're teaching them, that they understand it. We might have to even show videos. We might have to be creative. Like I took the information and put all these little colors and pictures on it. So it addresses their learning style. Okay, so we said at PI, we said first we assess. We're gathering all this information about their mood, about their judgment. And so let's dive deeper. So what is subjective? Someone come off you and tell me what is subjective data, and then someone else tell me what is objective data.
Subjective data is something you cannot see. It's just told to you, like by the patient. It's
Okay.
And then objective is something that you can observe. You can
Yeah.
see it by looking.
Like
Okay.
lab results and stuff like that. It's
So
subjective.
so give me that third person that was talking. I couldn't really hear it. What'd you
It's
say?
subjective have the labs and the
Say that
hold
again,
on.
Miss English.
Is
It's
it
like
lab?
blood pressure and different things like that. Things that you can actually see.
I was gonna say, like, if somebody has a funny gait or like if their gait's off when they're walking.
That's subjective or objective. You are describing what their gait is. Would you say that was?
Objective.
That's objective. Okay, because you're using your 4 of your 5 senses to describe and give as much detail. And we compare it against things that are, what we say, quote unquote, normal. Steady gait, unsteady. We use those descriptive terms to describe that. Okay, so my next question was to give examples. So we gave definitions and then we gave examples of both. So subjective data is the information that the patient tells you. Remember, we're establishing these therapeutic relationships, we're gathering all this information, we're trying to see about their judgment. So we're wanting the patient to tell us things. Then we are observing them as they discuss and tell their vital signs. We're looking at their facial expression. Are they making contact? Is that contact sustained? Is it glaring eyes? Or is it looking and looking away? Are they frowning? Is it facial grimacing? Are they crying? So we're using both of these. We're gathering all of this information as we are talking with our patient. So objective data in mental health assessments are observable. I think that's what you all just said, that can be measured and verified. So we're using 4 of our 5 senses, those things that we see, we hear, that we smell. And what was the last thing? Oh, and that we feel. We're not tasting anything. So that's why I said 4 of our 5 senses. So, and you all told me subjective data. I think we were spot on with this one too, as they are based on the patient's personal experiences. I feel sad today. I'm hungry. Or their beliefs that cannot be independently verified. So the person says that they're hungry, that's just what they said. We can't, there's no test or anything we can do to verify that. But subjective comes from the patient, the client, whatever setting you're in, they call them different. They refer to the person as, those things. So yes, we were spot on with that. All right. So we just said objective is those things that we are observing. Subjective is the things that patients are telling us. So let's take it a step further. If we were describing what a labile effect is, what would you all say? Let me put it in the chat. Put it in the chat. So send it out so everyone can see. Let me turn our timer on. Let me give you about 2 minutes to just get your thoughts together. I want you to paraphrase. So you are placing in the chat a sentence or a word or some words that describe what does a labile affect? What is that? What does that look like? And then we got the timer here. Give you some time. Put myself on mute because
What
sometimes
was the question? Can you ask the question again?
right here on the screen. Can you see my screen? So I want
Oh
you to
yeah.
define, put it into your own words, what labile effect is. Let me know if you can't see the screen because sometimes these things do go out. So you're paraphrasing, you're telling us what it is. Okay, me go on mute so I won't keep talking. I'm giving you time to gather your thoughts and think about it and put it in chat into your own words. Don't change what the definition is now. Paraphrase it. I'm gonna stop sharing so I can see. 33 seconds and we should be finished with that. Okay, I lost y'all. Okay, there we go. All right, let me see what you're putting in there. Okay. All right. So test taking tip, and like to drop those little nuggets as well. If a question gives you a scenario, I should have started with some of those test taking tips as well. Okay, our timer is up. So if the question is asking, has all this information in there, I need you to sift through and pull out what the question is really asking about. So, and if the question is about someone having a labile effect, they give you all these, the sun was shining, the person, they came in, they were late for work. They give you all this information. I want you to sift through that. If the question is about the labile effect, go back to what you know, your foundational knowledge, your understanding of the definition, and then match it and see if the response is matched. That was just a test taking tip. You can apply that to whatever. Okay, so labile effect is characterized by rapid and often exaggerated changes in emotional expression. It is considered abnormal and may indicate mood disorders or other psychiatric conditions. So that's that labile effect. Now I need you to look at what you put in the chat and see if you're going to give yourself a check mark or X. Okay. And you don't have to tell me. You don't have to just say it, but I want you to, and that's why I say you have to understand the concepts in order to be able to apply them and answer the question. Okay. That it looks like everybody was pretty much on task, on point though. So untreated bipolar disorders can lead to complications such as substance abuse. And so why do you think that any untreated mental health disorder, for the most part, can lead to substance abuse? What do you think can lead that? Someone come off mute and just share what you think.
It's a patient's trying to treat themselves.
Okay.
They know there's something's wrong and they don't have the medicine for it, so they're trying to treat what's wrong, trying to do what makes them feel better, whether
Exactly.
it be illicit drugs.
Exactly. Whatever it is, because it sometimes they do report where, hey, this helps me to settle down or be able to think clearer. So not just untreated bipolar, but many mental health disorders, if they lead to that substance abuse, because whatever those substances are, for some reason, it kind of like I said, helps them focus for that moment. As individuals may attempt to self-medicate their own symptom as well. And then on the other hand, sometimes people don't want to take the medicines that they've been prescribed for their diagnosis because they said it makes them feel weird. They eat too much. You hear that a lot. And it just makes them not feel well. Maintaining a consistent sleep schedule is something else we want to encourage them. That's for all of us. You just feel different when you wake up. You're like, whoo, I rested last night. So, but maintaining a consistent sleep schedule is crucial for managing bipolar as well as other mental health disorders, as well as sleep disturbances, because that just getting that rest, it helps you just feel better and function as we should. Another one, deep breathing exercises. And I know this one, right? This doesn't have anything to do with mental health, but when we're checking vital signs, people come in, you think about it, walking in the door, we have them, we call their name, they come on to the back, have them jump up on that scale first. That scale is not a lot of people's friends. So people, to me, get frustrated or their heart rate just goes up because we ask them to step on the scale to get their weight. So the next thing we usually do is sit them down and get their blood pressure. So what I have often did is just have people to sit there for that moment to gather themselves and do deep breathing exercises. Now, I'm not going to say it's going to lower their blood pressure, but at least we're getting them at that steady state, that calmer state. Deep breathing exercises are effective. It is one of those non-pharmacological techniques that we use for in a lot of things that's going on with patients. So making sure that they get enough sleep, and then those deep breathing exercises. Take that deep breath in and just let it out nice and slow. Just do that a couple of times and then just breathe normal. And then we proceed on with whatever procedure. or our task that we're having to complete. Emotion-focused coping strategies aim to manage the emotions associated with the stress. So we have emotion, we have problem focused strategy. These include exercising. Remember, we don't want them to exercise before going to bed, before it's time for them to go to bed, because then that gets them all riled up, and it does like the opposite. The person will be have a hard time sleeping. When we talked about that. So emotion focus. This includes exercising, seeking that social support, and meditation. And meditation it doesn't have to be where you have to go to the YMCA. It could be where before you walk out the door, you just sit and do those deep breathing exercises, refocus. And while you're doing that, you can look at your schedule, your list of things that you have to do today. If you create a list, put your ones, twos, and threes so you can do your things in order. But that helps you to redirect that stress and that anxiety. So then problem-focused coping strategies involve direct actions to address the source of the stress. What is it? Is it because, I got a little anxious. The storm has kind of passed over now. I know we had class. And nothing I could do about the storm, but other than tell you all, hey, if I lose you, just stay right there. I'll log back in. But, what's the issue? Is it because, we have clothes piled up, don't have my uniform to wear to work? What can I do about that? I need to stop and do the laundry or have someone assist me to do the laundry. What is that problem or that issue? And this includes problem solving. It can include cognitive restructuring and time management. That time management, you all, that's a thing. That's a thing for everybody. It's like you just run out of time. I don't know. I know this is the same time, even though time goes forward and backwards. We're all on these different time zones. It's still really the same time if you step back and look at it. But it just seems like it just goes by faster. And then, when the time changes in the fall, it's like, oh, time that goes by slower. And what's another thing to associate with that? What is it outside, like right now? Well, where I'm at right now is daylight. And so if the time says a certain thing, we kind of associate a time with darkness and light too. So that's the thing we'll talk about here in a few more slides. So maladaptive coping strategies. What is that? If they're maladaptive, I should have capitalized that in. What's maladaptive? Is that good or bad, or is that healthy or unhealthy?
It's kind of in the middle. It's like they kind of got it in some areas, and in some areas they need to work on.
Okay, so if it's maladaptive, it is not a good coping strategy for that person. So if that strategy, going back to that substance use, if that's their strategy of, consuming alcohol or whatever to help them refocus, that's going to eventually lead them down the wrong path. So maladaptive is not a good coping strategy. Okay. Effective coping involves matching strategies to the severity, the duration, and the situation. Clothes, laundry is not done. Late for work. All those require different responses. All of those require different responses. So we want to seek out what is the issue and then try to match or list coping strategies that are specific for that. Because if you're telling me how to rearrange and get my laundry done and that's not the problem, remember, you're not helping me as the patient. So we do want to match the coping strategy to what the issue is that the patient is the stressor, whether or not it's time management, not getting enough rest. As we're talking to our clients, you're not getting enough rest. Well, tell me what things are you doing before you go to sleep? Well, I run those 5 miles. Well, you remember we said we don't want people to exercise right before they go to sleep because more than likely, usually it keeps that person alert and they have a hard time falling asleep. So we talked about this too, post-traumatic, and we're still reviewing. We're going to get to our new content here shortly. So post-traumatic stress occurs in response to a severe traumatic event. And it's whatever that person deems as severe and traumatic and can lead to but it also can lead to long-lasting psychological impacts. It's something that's happened in the past and that person deemed it as traumatic. Okay, so here it is. Let me hear from you again. What are the effects of chronic stress? on body system. So in the chat, just put it in chat, and I'm going to look at your responses. So we're talking about this stress thing. So we're just not talking about just regular stress. We're saying chronic stress. What can it do to a body system? We have the cardiac system, we have the musculoskeletal system. What can chronic stress do? What do we think? Chronic stress. Let me do my little timer because I asked you all these questions and I don't think I give you all enough time to respond. So, what are the effects of chronic stress? And you can just take one body system and just kind of list what you think. Okay, let me see what you got. So we're taking a body system. That's stress. That stress, you all. We can't taste it. We can't really see it. But when I tell you that thing is real, it's real. So yes, high blood pressure, weight loss, weight gain, blood pressure rising, skin breakouts, and you all are spot on. Hair loss. Yes. Weak immunity. Exactly. That's right. So let me go back to my little slide here. So chronic stress can lead the body systems to halting, not functioning as they should. It can send them in overdrive. It can stop them. The body systems can have spurts of overdrive, underdrive, and so with that persistent, when in the example that I have here is the cardiovascular system, and you all said that as well. Some people said pain too. That persistent increase in heart rate and blood pressure over time, it can lead to cardiovascular disease. It could lead to chronic pain. So yes, it can just make all body systems just go haywire because it will have the systems to not do what they're supposed to. And so this other time. So generalized anxiety disorder, we said GAD last week, is characterized by persistent, excessive worry about various aspects of life, often without a specific trigger. That consistent, that persistent, excessive worrying. It's more than just, oh, I'm thinking, my child isn't home yet. And so, okay, they're here. So, we go on to sleep and everything is at rest. No, this is persistent. The child is here. I'm still upset, worrying. It's persistent, excessive worry. And that is that generalized anxiety disorder or GAD. The availability of weapons, especially firearms, is a significant factor in relation to suicide. I think I got this slide out of order when I was trying to rearrange them and put some color to it. In countries where ownership of guns is prohibited, suicide rates are low. For example, in the United Kingdom, owning a handgun is illegal. The suicide rate is less than 1/3 of that in the United States, where gun ownership is hotly debated and defended. So we're not for weapons or against weapons, but we're just simply saying that data shows where guns are not readily available, the suicide rates are lower. That's all this is saying. We have the psychiatric model. It interprets substance abuse as a manifestation of underlying emotional conflicts. We just said we were asking about why do we think people, go to the substance abuse. So they may have that underlying mental health disorder, or it might just be that they haven't figured out effective coping strategies for whatever the stressor is. So, and so whatever that is. So the first step in treatment is for the individuals to recognize the need for help, because we want our patients that after we establish those therapy relationships, they'll tell you, they'll tell you what's going on, and they'll just say, I need some help with this. As denial is a strong part of most substance related disorders, but initially when they're trying to work it out on their own, they're using that substance abuse, their substances, they will be in denial and think that they don't need any help, that the alcohol or whatever the substance is helping them to effectively cope. You know, we talked about the medications. Lithium has a narrow therapeutic index. It requires that routine monitoring. So when we were asked the question about judgment, when we're having our patients when they're taking these medications, we're trying to check their judgment. We said, well, hey, this medicine is going to make you sleepy. You operate heavy machinery as your job. You think you need to have a conversation with your boss, supervisor, to maybe change up your task for a couple of weeks. Hopefully that person says yes. That tells us about their judgment. Now, if we're telling them that they take a medication that is going to require them to come in for routine labs and they don't show up for routine labs, that means their judgment is not good. Lithium is one of those ones we must draw that blood. Was there a question? No. Okay. So SSRIs, they can potentially cause serotonin syndrome, especially when combined with other serotonergic medications. So, but usually the pharmacy with once if a doctor happens to put an order in and the medications are going to bump head or have some type of conflict, pharmacy will call you on it and they'll remind you about it and they'll verify that is this the way you want to go. So MAOIs, they remember those foods. We want to make sure that we reinforce those dietary restrictions. These are the foods that you might want to stay away from. More than likely, you need to stay away from these foods. TCAs can be cardiotoxic in an overdose with the risk of life-threatening arrhythmias. So we want to make sure they're coming in. We want to reinforce that teaching about checking the pulse and all those things. Blood pressure and all of that. These safety considerations are crucial for nurses to understand when administering these psychotherapeutic medications. And so you're like, okay, these medicines help one thing, but they sure can cause problems with others. And so that's why we want to be proactive and arm our patients with this information. Hey, we're going to need you to come in. In the event that you start experiencing tremors, stomach get upset, we need you to report that because you might be a little lithium, you might have too much lithium on board. So these are the things we want to teach them. We want to be vigilant about toxicity, because, if a person, it just depends on what's going on with those body systems. Sometimes those medicines are, processed through the body and they're, the waste products are excreted, but sometimes they build up. So it's going to be very important that we do that, reinforce that teaching. Okay, let me give you a minute. Fill in the blank. Put in the chat what you think the answer is. Let me find my little clock again. Blank is one of the most common side effects of benzodiazepines, which are often used to treat anxiety disorders. Let's see, how did we do? 26 seconds left. And we are saying drowsiness. How did we do? We call on your prior knowledge. Okay. Sedation, drowsiness. Yes, you're right. It is one of those common side effects. All right, let's do it again. Blank. Stop my timer. Pause. Let me delete it and reset it for 1 minute. Blank are often the first line of choice for treating depression due to their positive response rates and decrease or reduce side effects compared to other antidepressants. 17 seconds. Let's see what you got. SSRIs. Good. Let's see what most of y'all put on here. Let's see what it just said. Got it. Y'all are rocking and good, good, good. So that means we got that information. So we're gonna add on to here in just a few minutes. We're gonna be going somewhere. We providing that best care to our clients. We rocking their NCLEX, the HESIs, and all that stuff. All right, here we go. Because remember, I said in week one, you want to, for all your classes, you want to just go back. You just got to go back and chunk it up, continue to look at it. Because for one, you never know what setting you're going to end up working in. NCLEX, you never know what questions. HESI, you never know what questions. All right, so clonazepam can cause gangrene. I'm saying this word, lysotosis. Somebody pronounce this word for me. My tongue is twisted up. Someone say it for me. Necessitating regular monitoring of white blood cell counts. So remember, this is another one. We want to monitor those labs. Got to get the people to come in. Got to get them to come in, and we don't want it to be a surprise. So when the doctor gives them that order, and we're reinforcing that information, we're saying, hey, remember, we're gonna need you to come in. What's something we can do before they leave the clinic in regards to getting these lab works done? What's something we can do before they leave? What do you think? Let's be proactive.
Give them an appointment for labs to come back.
Exactly. Go ahead and give them that date and time, even if they have to change it. Give them that phone number if they have to change. Go ahead and just put it on their calendar. Hey, we need you to come back in 6 weeks. So 6 weeks will be whatever, December 1st. We have times at blah, 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 blah. Hey, we're going to put you down for this. And they may say, well, I really don't know. Well, let's just go ahead and put you down. And then I want you, and even if they have a calendar, what kind of calendar do you use? Do you use electronic calendar? Got a paper calendar? Did you bring those with you today? Let's go ahead and pull up your calendar. Let's go ahead and put it on there. Then I want you to, another thing I found out is get people to go ahead and say the number. Like for example, if you're at the urgent care, if you're at the doctor's office, wherever you're at, which facility you're seeing your patients in, go ahead and get them to say the numbers in their phone. Because if they're in a crisis and they have a quick question, of course my mama said ask Google, but still, if they know Dr. White, Dr. Bob is already in their Rolodex, they hit it. They're more apt to go ahead and follow through with calling rather than having to take those extra steps to look on Google, stroll through, and all of this stuff. That's another thing that I've found to be effective this week. Go ahead and make the appointment, even if you have to change it. You have to change it. Here's our number. Go ahead and put it on your calendar. Was there a comment, you all? All right, so here's another question for you. Do mood stabilizers, valproic acid, have any specific dietary restrictions? What do you recall? Okay, I got one response. Yes or no? Are there any dietary restrictions? Are we giving them any instructions about their food, their nutrition, if they're taking a mood stabilizer? So that was the same question. I just reworded. And that's another test taking tip. When you are taking your exam, if you don't change what the question is asking now, you can reword it, reparaphrase it like I just did. Okay. Unlike some mood stabilizers, valproic acid, it does not require specific dietary restrictions. That's one that don't. Okay. All right. Atypical antipsychotics like risperidone, or Risperdal can increase the risk of developing diabetes. These symptoms warrant immediate assessment. So if your patient's coming in and they are, what are the 3 Ps that you learned in med surg? And put the 3 Ps in reference to diabetes. What are those things that they're going to be complaining of?
Like polydipsia, polyuria.
I'm
And
so thirsty. Ooh, I just
yeah,
been thirsty lately. I've been having to, urinate a lot. So because we know that they're on these antipsychotics, specifically Risperdal or Risperidone, we want to ensure that they're following getting those labs. And if they are complaining, coming in and complaining those signs and symptoms, because we know that this increases a person's risk. We don't know if they have diabetes, but because they're complaining those signs and symptoms of subjective data that they're going to tell you, bring it all together, you all. Diabetes, you've had med surg. And so the endocrine system, what is those, what the pancreas on those things supposed to be doing? So we want to make sure that we reinforce that education. Say, hey, if you're experiencing these things, we need to know. You need to call us immediately because we need to do that assessment. Okay. So benzodiazepines like prolozone, Ativan. What are some side effects? Come off me and tell me. What are some side effects of Ativan, benzodiazepines? What are some side effects? What you got? This one's always out there, drowsiness, which can impair the cognitive function. Okay. So we've already said we want to tell those patients, be aware, be aware. And yes, that little scenario about them having that conversation with their boss, because we rather them talk to their boss. We're not wanting them to violate HIPAA or not sharing information they don't want to. But I rather them share that information and be safe, that they don't cause any harm to themselves or anybody else out there while they're still excuse me, trying to work. Excuse me, and also see how these medications are going to affect them. All right, so here we go. You all did pretty good. Y'all rock with that prior information. So let's keep going. We're gonna build upon it. All right, so we're talking about emotions. Emotions, those were all of your objectives. So human beings engage in aggressive or violent behaviors for a variety of reasons. Human reactions can be placed on a continuum ranging from calm to violent. Okay. Healthcare providers are legally required to report suspected cases of abuse. Okay. So the first priority is helping that client or that victim of violence to make sure that they are safe. Make sure they are safe. Okay. We want to discuss the meaning of agitation, aggression, abuse, violence, neglect, and exploitation. So take one of them, take one of those terms, and then come off mute and just tell us about it.
Like, what do you mean? Discuss about what?
Take one
What
of
do you
these
want to know?
terms. Tell me about agitation. Tell me about aggression. You select whichever one you want. Neglect. What is neglect? What is exploitation?
Okay. I guess you would look for neglect, like if they came in like filthy or wet, like a wet depends or something, or breakdown of the skin, odor.
Got it. Good. All right. Uh-oh. Is this a
Signs of
blank slide?
abuse would be like,
Go ahead, Miss Kelly.
signs of abuse would be like bruises or multiple stages on their body, bruises, multiple breaks, lots of previous visits to the doctor.
Exactly. And also, I think you mentioned bruises and marks on the body, on the skin. If you see marks and bodies on the skin that look like common things, for example, that looks like a fork or things like that, like, wait a minute, that looks like the imprint of, um, you want to make sure that we're reporting. It could be just the child was doing whatever, it could be their birthmark, it could be just a skin discoloration, but we do want to look into that. You do see that often too, where they have those discoloration on their skin and it's, due to that skin being burned or something, something happening to that skin as a result of being abused. Okay, so we're going to talk about the dysfunctional family. Make sure you refer to that box. It's 26.2 in your book here. And remember, all of this is on these slides that you already have prepackaged. So no one is certain exactly why violence occurs. Nurses and other healthcare providers accept and care for everybody. It's just what we do. Aggressive and violent acts are committed by members of every group in society. But we found out what studies have shown by collecting data from people that poverty sometimes played a role. We're not saying it's an excuse, but it does play a role in someone being violent. So, how does violence influence the members of a society? Okay, so how does violence influence the members of society? What you think? If something happened at the Walmart, something violent happened at the Walmart, what do you think
Mhm.
about
It
going to that
could
Walmart?
it could give people trauma, like
E-
PTSD, if
Exactly.
something like that.
Yes, remember, and what is PTSD?
Post-traumatic stress disorder. This is when something traumatic has happened in the past and it's still affecting you, I guess in the present is how I would describe it.
Got it, spot on. And those things can affect that person being a productive individual, going to work, socializing with others, running to the Walmart or the Kmart or to the CVS. All of those things can have a domino effect. While not a direct cause, substance abuse is often associated with an increased risk of severity of interpersonal violence. We're not saying that poverty is a reason or an excuse. We're not saying that substance abuse is a reason or excuse. We're just saying we are seeing that, that's an additional thing that we see if someone is being violent. Poverty, substance abuse. And you think about the substance abuse, a person is not as, those substances alter your mental status. So they're not making judgments and decisions as a sound judgment. Like we just that may go back to that side. So they're not making sound judgments or decisions correctly or thinking things through because they have that substance on board. Okay. So there's some theories in violence. Psychiatric or mental illness model views violence as a mental illness. The psychiatric mental illness model views it as violence as a mental illness. Okay, so it's listed there, but this theory is saying just like generalized anxiety disorder, post-traumatic stress syndrome is listed, it's saying that violence is a disorder as well. Social learning theory views aggressive and violent behaviors as learned by role modeling in other environments. What we do see a lot too is if someone has, and I think it's on one of the slides, I just pulled all these things and just put one thing on a slide to you all. That was another thing I did. Some of the slides that just have so much stuff on it. If a person has seen violence as a child, then they sometimes, you know, display those same acts as an adult themselves. Sociological theories credit environmental and social factors, you know, where I live, you know, it may be poverty stricken. It might be that I want to be a productive citizen and get a job, but where I live is too far out. I can't get to the job. And so that environment creates you know, in itself need a person to cause violence. These are just theories. I can't talk today, y'all. Theories. That theory right there on the screen. Studies of the study of social history of humans. Feminist theories use the concept of macho to explain the occurrence of violence against women. Chauvinism. Define it. Okay. So look at in that same box, 26.1 is there. That compulsive masculinity. Okay. Okay. So you kind of started talking about this early on about, I know we talked about it last week because I was asking about what place was it that only had like so many hours of daylight, and it's a small amount of daylight. I forget what place it was, but anywho, and remember I just talked about with the time change, how we'll look and say, well, okay, it's 8 o'clock, but then it's still daylight outside, 8 p.m. and it's still daylight outside. So we kind of get confused, our rhythms get off because we're seeing that daylight. So seasonal affective disorder or SAD is often effectively treated with light therapy. How about that? Putting the person out in outside or having a room where the lights are on, which helps regulate the circadian rhythm disrupted by that seasonal changes in light exposure, especially if they live in those areas where, and there are some areas there that light, there's a very small window during the day that they have light. Where is that at, you all? I know I'm not making that up. I
Is
don't know
it
where
Alaska?
is
It's
it you
Alaska.
Alaska, yes. So their window, like for daylight, is very small. Is it like 2 hours in a day? It's very small compared to, what, the norm is. And who would have thought, being exposed to light, nobody, the sunshine and vitamin D and all of that. But really, it does affect a person's mood. Okay. So chronic anxiety, I maybe went overboard this slide right here with this little stuff in the background. Let me move that down. Uh-oh. I don't think I can convert them right here, but I'll read it. Chronic anxiety can lead to various physical complications, including an increased risk for GI. I think someone said that when I was asking about the body systems. A lot of times you see someone that has anxiety, or just think about when you get nervous. Oh, my stomach hurt, feel like I, need to throw up or whatever. Sometimes people experience those GI disturbances. And so just imagine if it's chronic anxiety. And that's that prolonged stress on the body. Trying to watch our time here. Okay, so let's pause, you all. Let's just do a 5-minute break. I know we gotta do our seat time, but what we can do, we do have the power to adjust our break time. Let's start off with just a 5-minute break. You all are going really, really good here. Let's just come back at 6:37, and then the next break we'll do a 10-minute break. Okay, remember this thing
Okay,
before we
don't forget
play?
about our couple minutes from last week.
Wait a
So
minute, a
I ain't
couple
forget.
minutes. It was 1 minute. See how? Wait a minute.
I
It
ain't
wasn't
forget
a
about our
couple.
time from last week.
It was one. It was one. Yes. So we have that 1 minute at the end in addition to. So we're gonna do a 5-minute break for now. So come back at 6:38, and then the next one will be a 10-minute. We'll try to push if we can that break time toward the end so you all can, finish before midnight. See you in 5.
Yeah. All right.
Camera went off now. Okay, so let's see. Where did we leave off at? Let's see here. Let me share my screen. Okay, so we left off with talking about that chronic anxiety, which that was, we repeated that it affects all body systems. We talked about, nausea, vomiting, diarrhea, that heart rate being up, high blood pressure. It can negatively, over time, it can help that body to develop into chronic diseases like hypertension and so forth. Okay, here it is. All right. So overgeneralization, a cognitive distortion common in depression, where every single thing that that person says is going to be negative. Well, I'll just never be good at anything. I mean, they just summon everything up into never. It's always a defeating response. It's negative and it includes all inclusive. So that's that over generalization. Okay. Safety is going to be, we got to keep safety in mind no matter what, if we're in the community working, if we're at the urgent care, the hospital, wherever, we got to be thinking about safety, our safety and the patient's safety. Assessment for suicidal ideations ensures early identification of the risk. Usually there's a, when we do triage, there's part of there's a questionnaire, there's some questions that's there. Well, we ask, have the person do they have any suicide ideations? Removing hazards and close monitoring prevent immediate harm. We want to be looking in the environment, ensuring that things that don't need to be there are not there. If we're supposed to be making rounds every 15 minutes, if this person is a one-on-one, and some of you are as you may have been working in the hospitals and you might be a sitter and you see patients, or you've been through your clinical rotations, you see people have that one-on-one sitter. Whatever they come up with that care on that care plan, we need to be providing those things. Those things are there so that client can be safe. Emotional support helps build that trust and that therapeutic rapport, establishing those therapeutic relationships up front. And that helps de-stress the whole situation. A safety plan empowers the patient. So we're giving them some not maladaptive coping strategies, but some positive things to think about, and strategies that will empower that patient. Okay, so domestic violence, workplace violence, community violence, and self-directed violence. Domestic violence refers to abuse within someone from the family. These things are real, you all. This is not just something in a textbook. This stuff is real. Workplace violence, you hear about it a lot. Seems like more now with nurses being harmed, in the places that they're providing care for people. The community, it involves an act between unrelated individuals in that public area within that community. And then self-directed violence includes behavior where individuals harm themselves. Okay. So a history of stroke may include residual deficits like slurred speech, which can be mistaken for signs of toxicity, for intoxication. So we want to make sure that we get that in-depth history, because sometimes people they can come off as like they may be drunk or intoxicated or something, but really they may be toxic, have taken too many medications, and their levels are, out of range. That person could have had a stroke, even though they're moving all their arms and legs. That residual might be their speech. And there are always variations of that when someone has a stroke. It's like, okay, a person tells you they have a stroke. Some people walk in, moving all extremities fine. The voice is clear. I mean, the speech is clear. And then some people, they require two-person assistance. So there's that variations with that. So we always want to make sure that we do that, what we said, that assessment, that first step, to gain all of this information so that we can understand what we're seeing with this patient. Is it really because they have substance abuse, or is it because their lithium level is toxic, or is it because they're in one of their manic episodes, or their stress is so high they can't calm down and have a conversation to answer questions. So exposure to parental violence during childhood is a strong predictor of future involvement in domestic violence. And what they're saying is the child acts out what they have seen. So domestic violence, abuse, and battering within the family. It is estimated that one American woman of every two will be physically abused at some time in her life. Dysfunctional family. Violence within the family occurs in several ways. It can be physical, emotional, sexual, neglect of partners, child abuse, and elder abuse. Remember, we are those mandated reporters for the children and the elderly. Okay. So why would you think domestic violence is often unreported? Why do you think that is often unreported?
Because the person that loves you is abusing you, and you don't want to tell on the person that you love.
And then, or you're embarrassed about it.
Yeah,
Exactly.
I'll say that too.
Okay.
Or you're scared it's gonna happen again, or you scared they're gonna find out that you said something.
So incorporate what you all are saying when you're talking to your clients and your patients. You want to mention those things to them. Now, I'm asking you, are you being harmed at home? And I'm not saying that you are, but I know that sometimes people don't report what's actually happened because, they may feel embarrassed. They may feel that it's going to happen again. So incorporate some of that in your conversation so that you seem real when you're talking to your patients, so that they're like, wait a minute, my nurses, they're not real. They don't understand. So incorporate some of that in there. You're not saying that that's what's happening to them, but you want them to feel free to tell you so that you can seek out resources for them. People often resist the state's intrusion into their private matters in their home. So, if we establish those therapeutic relationships and they give us information, we want to make sure we have resources. What are their next steps? That they have options. So then they are more likely to, tell you what's going on. Because otherwise they may look at it as, well, I'm just telling this person this, they said it, or I'm just telling them my information. They're not gonna help me. So, but if we convey to them that we have resources, or these could be your next steps if this is happening to you, then they're more likely to give you that information. So the next box is that 26.2. Make sure you look at that. It just describes those characteristics of those dysfunctional families. And what we mean by dysfunctional is, do they have resources? Do they realize that they can reach out in the event that a crisis happens, a storm comes, and they're out of power? Do the people that are in that family, do they realize what the next steps are? Do they need to seek shelter at the shelter that's in the neighborhood? Are they going to a neighbor's house? And that's what we mean by dysfunctional. In the event that something's happening, are their responses reasonable and safe? Okay. So, in a characteristics are, people are self-centered, authority is inconsistent or lacking, roles are not clearly defined, family members are unable to meet their needs and the others' needs. Okay, and so those are just some examples that I gave. So a storm happens. What are our plans? So a gender abuse. There is no typical abused woman. Characteristics of an abused woman: trusting nature, raised in a non-aggressive and traditional home, believes that the man is the master and protector of the household. Characteristics of an abuser of women: poor emotional control, superior attitude toward women, history of substance abuse, high levels of jealousy and insecurity. So this person is not thinking reasonable and not thinking clear. So those refer back to those charts. Okay, so recognizing aggression and violence in personal thoughts, attitudes, and responses is crucial for developing more effective methods of managing emotions and preventing violence. So if we ourselves and we teach our patients, family members, and all, when you feel yourself not having the next steps or feeling yourself getting worked up, this is how, these are some coping strategies you need to consider. Maybe stepping back, do some journaling, writing down your thoughts, call in that trusted individual and tell them, I don't need you to say anything. I just need you to listen. I just need to talk through what I'm experiencing. But recognize, that aggression and coming up with some positive coping strategies so that the violent act does not occur. That's the whole intent behind that, because we don't want a person to be violent. Nurses should conduct a thorough history, because that's part of our assessment, including current and past medications. Because if you might ask a person, do you have a diagnosis of generalized anxiety disorder? And they may say no, but then you'll look and see that they're on a medication for that. Even though we do have off-label uses for meds, they might not have understood that's why they were taking that medicine, or what of that, or that's what it was called, the diagnosis that they had. Okay. And so we do review all the body systems, as we just said, all that undo that chronic stress. It can make your stomach hurt, make your head hurt, high blood pressure. Many people who must cope with chronic illnesses entertain thoughts of suicide. And that is real, because sometimes they look at it as, they're always having to go to the doctor. They're always sick, and they, are thinking that them just not being here is the reasonable next step. So so that's a question that they pretty much ask everybody, especially when you're going into the hospital. And I want to say, they ask you that down in the doctor's office. So that's just a routine question that they ask, just to make sure, so we can seek out resources if needed. What about this right here? Overcrowding can lead to violence. Well, how does that lead to that? Overcrowding can lead to increased stress and conflict, potentially escalating to violence. So we're talking about this dysfunctional family. What is overcrowding? So we have a home and we have 20 people in the home. Or we have a home, we have 2 bedrooms, and there are 10 people that live there. How's that going to lead to stress? Talk me through that.
Maybe not having your boundaries met, like somebody constantly overcrossing your boundaries in different forms.
You're like
Exactly.
leaving a
Or
mess.
feeling left out. Too many people that you're feeling left out.
You might not have privacy either.
Privacy, yes. So
Not
yes,
everybody's as clean as one another.
okay.
It drives you crazy.
So overcrowding can lead to stress and potentially escalate to violence. Exactly. So it can. For some women, pregnancy only increases their chances of being abused. So we do, of course, we're asking these questions to everybody. Pregnant mom, everybody, do you feel safe? I think that's how that question is that we ask. I can't think of how it's worded, but they ask you, do you feel safe in your home? They even ask about your money. Do you have money to buy food? They ask about all of that. And it's just a routine question. We did have a patient in the ER. I was like, why are y'all asking all these questions? And it is some in-depth questions, but we had to, explain, hey, we're just trying to look at everything. I know you came in here because your toe hurt, and that's just an example. But we just want to make sure that before you leave, if there are other things that we need to address, that we seek out those resources for you. So yes, we're going to ask everything from A to Z, so to speak. And they're like, oh, okay. That's so the answer, if it's no, you just keep on saying no. But if there's a yes, know that we're going to try to seek out resources for you. Okay.
We have to ask every patient every time we work one up, have you felt down, depressed, or hopeless in the last few weeks and all this stuff. And they always say, why do you want to know every time I come in? I said, well, we have to for quality measures.
Got it. Yes. Though, and I think we talk about it much in here, but the Healthy People 2030, it talks about everything from A to Z, and it addresses everything literally. And so what they found out is that we are finding people that are down and out and have been down and out, and had someone intervened or pointed them toward coping strategies or resources that their current state where they might not be. And so that's why we're trying to be proactive rather than reactive with this. Yes. Okay. Adolescent abuse. The rate of abuse of adolescents surpasses that of young children. Abused teens are less likely than abused younger children to receive needed services and counseling. The three leading causes of death for adolescents are fatal accidents, murder, and suicide. Let me go back to this other slide, making sure we didn't miss anything off there. No. Okay, so how do signs and symptoms of abused adolescents differ from those of an abused child? Think about the child, you know, they're going to school. If you're an adolescent, more than likely you just out there, you go to work, but you're not under the constant surveillance of like the school nerves, and things like that. So they might go unnoticed. They may still have the same sign, the signs and symptoms, but they might go unnoticed because they're just out there, in the world rather than a child. Like they're going to preschool, they're at daycare, they're at the babysitter, they're at the swim class, they're at the dance class. So someone's always seeing them. They're always being monitored, so to speak. And so the adolescent, they're grown, they do their own thing. So no one's really seeing them unless they really want to be seen. So vulnerable adults, older adults, they're that vulnerable population. Again, the children and the elderly, they're that vulnerable population. And so, and elder abuse does include of their finances as well, not just physical, but their finances. Okay. So caregiver burnout and fatigue, they do have this thing called respite care. And we do know that statistics show that the person that's taking care of the person, sometimes they pass away or become more ill than the person that they're taking care of, because what happens is they don't take care of themselves. If for some reason we forget, hey, we're taking care of this person, but we also need to make sure we're drinking our water, taking our medicine, going to our doctor's appointments, making sure we're getting our walks in. And so it can lead to that burnout and fatigue. And as a result of it, that person can end up abusing who they're supposed to be taking care of, because it just builds up and they don't have any good coping strategies. They have those maladaptive coping strategies. They may turn to substance abuse, alcohol, and things like that. So we do know that abuse comes in all different forms. Physical abuse, and you all gave some examples: neglect, psychosocial, exploitation, and even this right here, social isolation. Your neighbor. We had the daughters living with the mom. We haven't seen the mom in 2 months. And I'm just making up stuff, you all. And so what happens is the daughter needs to go to work. And so in order for the mom to be safe, and this is just what the daughter is thinking, or the son is thinking, they lock the mom in the house. And so and then when they do come home, they don't let them out because they need to go, the child, the person that's working, they need to take a nap. So they just make sure, so you never, you only see the parent every now and then. That's social isolation or imprisonment. So we have to look for, when we say, abuse, like what does that really mean? What are some scenarios? Of course, sexual abuse is that unwanted sexual attention. Healthcare providers should routinely assess all clients for the history of abuse and victimization. And we have to report it. Okay, violence, trauma, and crime. Today's society is confronted with a steady diet of violent behaviors. Active violence, if you look at it, TV shows. I didn't even know one of the cartoons was, I forget which one of them it was. And I was like, wow, what in the world? This is a cartoon that's doing all this. But anywho, so we gotta just be careful what we're letting in our eye gate. That child seeing abuse, then they grow up to thinking that that's how we're supposed to cope. So we have to be careful what we let in our eye and our ear gate, because then somewhere in our mind, we get programmed, so to speak, to think that's how we're supposed to react. Okay, so the DSM-5 defines only one clinical syndrome as directly related to violence, that post-traumatic stress disorder. Okay, it directly relates it to violence. You all told us what that was. The rape trauma syndrome is a relating nursing diagnosis or problem statement that encompasses the essentials of care for victims of this violent experience. Okay. So our goals, we want to prevent violence from ever occurring. We want to, in the event, we want to seek out resources, identify positive coping strategies, non-pharmacologic if possible, journaling, calling that person to talk through whatever it is, talk to your person of faith, exercise to calm your thoughts, whatever those positive coping strategies are, because we don't want violence to ever happen. That's it, we don't want it to ever happen. Early recognition and treatment for violated individuals, providing that safety. What are those resources? What is going to be the plan? Okay. So forensic evidence is information gathered for legal purposes. They have where you can become that sane nurse, and that's where you help gather that evidence in the event that a rape occurs. So priority care is to ensure that client's safety. Safety, safety, safety. You're gonna be here to say ABCs and safety, you all. You hear that throughout your journey. ABCs and safety. Okay. We do want to preserve the evidence. We don't want to, jeopardize it because they use that evidence. They run the test on it to identify, who it is, what it is, and all of that. So we do want to preserve the evidence. Okay, so what nursing interventions can be used to help clients recover from violence? Okay. We want to explain all procedures, making sure they understand what we're getting ready to do before we do it. We so tend, if you have to catch yourself, you want to just go ahead and pull the covers back, put that blood pressure cuff on that arm. No, we need to identify ourselves, identify who we're talking to, and explain what we're going to do before proceeding, drawing blood, whatever it is. Allow the client to maintain as much control as possible. Allow them to be involved in their care. Okay. Preventing violence in your life. How does self-awareness lead to a decrease in violent, abusive, and exploitative behaviors? How do that self-awareness, being aware of what gets you worked up into aggressive tone, being aware of what makes you anxious, how does that lead to a decrease in a person becoming violent by them being self-aware? So let me hear from you. Come off mute.
I guess when you're self-aware, you know what triggers you and you utilize your coping skills in order to de-escalate your aggression and how the way you feel, like your emotions.
Okay. Anyone else would like to share? How does being aware of, on person, myself, being aware of what works me up and make me aggressive or anxious helps me to
You'll know what to
decrease.
avoid.
What you say?
You'll know what kind of situations to avoid putting yourself in.
Got it. Just don't even go that way. You see Sarah coming, Sarah's going to say something or do something to get you riled up. Just speak to Sarah and keep on moving. You're right. Don't even put yourself in this situation. Got it. Preventing violence in your life. It is important to remain aware that violence can erupt in any client situation. So when we're going, even if you're at clinical, you all, you still need to be aware of your surroundings, what's going on with your clients, what their diagnosis and things are, what they're being treated for, because violence can erupt at any moment. For the most part, we have to park in a certain spot, and usually it's not close to the building that we're going in, and you're walking across that parking lot. You need to be looking around and making sure nobody's going to jump out, or a dog or anybody's going to jump out and try to cause harm to you. So it is important to remain aware that violence can erupt at any client situation. Just because you're the nurse, it does not mean that people won't try to harm you. Sometimes it's voluntary, and sometimes it's unintentional. Client is disoriented, they're confused, they have substance abuse on board, and they're refusing care, striking out and everything. They're not themselves, but nevertheless, you could end up harm. So just being aware. When interacting with clients, watch for signs of growing anxiety. Remember, you all told me we're going to assess first. Watch for that, those responses. Is their voice changing? What about their posture? Are they, and when they're talking to you, are they balling their hands up, making fists? Are they hitting on the table? We want to use our assessments findings and as we interact with our clients. If this question that we're asking, are they getting agitated? That they turn away from you. We want to make note of that. And so we might have to call in for assistance from another provider. We may have to switch out nurses. We might have to leave them alone and reapproach at that moment. But learn to recognize aggression and violence in your patients. So just make sure that you are paying attention to that. All right. Any questions? Any questions so far? All right, let's go ahead and do a substitute here. Let me get it pulled up. So that was us looking at reviewing from last week, bringing to forward. We looked at violence. So let's go ahead and let me find it here. Let's see if it's probably gonna make me log back in again. I had pulled it up. It's spinning. All right, let me get it so we can put in the code. I'm gonna share my screen here in just a moment. Okay. All right, I'm gonna share my screen. So go ahead and go over to www.kahoot.it and then enter this code. I'm gonna share it in just a moment. Okay, at least log in with at least your initials. I can't hear the little thing. Give you a little bit more music. Again, remember, if you have to walk away, use restroom, or take care of something real quick, just put a message in the chat to myself to tell me why you are not on camera. Make sure you do that. All righty, are we ready to Kahoot it? Here we go. I'm gonna go on mute so I can let you all concentrate. All righty, you all did pretty good with that. All right, let me turn it off and we'll keep on moving. Leave. Okay. All right, so now pull up our next PowerPoint. I tried to put colors and designs to all of them. Let's see here. Where did it go? It's trying to open. Usually don't take this long. So if I lose you, if connectivity drops, just stay right there. I'll be back. Because it usually doesn't take this long. Okay, it's moving. The weather has calmed down, so. But sometimes with this connectivity, there's no rhyme or reason to it. It does what it does. What it do. Okay, come on. All right, it's opening up. Let me just download it again. Share. All right, so this time we're looking at the inward emotions. First couple of slides, are always our objectives. Okay. So for all of your diagram, the figures that you have in your chapter, just make sure that you're looking at those. Okay. So maladaptive, we talked about that word early on tonight. Maladaptive self-protective response, if not changed, will eventually lead to self-destruction because we said maladaptive is something that's not good for you. So self-destructive behaviors are classified as direct or indirect. Direct self-destructive behaviors, any form of active suicidal behavior, such as threats, gestures, or attempts to end one's life. Indirect self-destructive behaviors, any behavior or behaviors or actions that may result in harm to the individual's well-being or death. Myths about suicide. Suicide has always been present in society, but little effort was made to understand its nature until the beginning of the 20th century. These are myths. Many false ideas about suicide exist. People who talk about it will not commit suicide. That's a myth. One does not need to take a suicide threat seriously. That's a myth. Only psychotic or depressed people commit suicide. That is also a myth. Okay. 10th leading cause of death in the United States. This is talking about the impact of suicide on society. Second leading cause of death among people between the ages of 10 and 34. Second leading cause of death. 20% of all suicides occur in white men older than 65 years of age. It is important for nurses and other healthcare providers to be well versed in recognizing, not only just recognizing, but intervening when with the clients who are suicidal. It's not good to just to know and recognize the signs and symptoms, but what are we going to do? We need to intervene. Identify cultural factors that are related to suicide. Culture usually includes a view of suicide, laws, customs, beliefs, values. Customs and rituals may play a role in suicide. So while we're establishing those therapeutic relationships, we find out, what's important. What do they value? What are the norms? What does your patient consider norms, in their environment? Okay, so many that have chronic diseases, we mentioned it on the last talk about, a person will, might think, that they're having to go get all these tests done. They were in remission, now they're not in remission. They went through all of that treatment, and they experience, because some of that treatment for some chronic disorders is hard on the body. People, they lose weight, and they lose their hair, their whole appearance might change as a result of them taking the treatment that's supposed to be good for them. So as a result of that, sometimes that can lead to chronic stress and maladaptive responses. So we want to be aware of social changes in this world, as they may offer clues to caring for clients who are thinking about ending their lives. Having those conversations, no change is too small for you to just follow up on, a change in a client. And I think we have it on the slide here. They're packing up and giving away their things. Like, oh, okay, Mr. Patient in room 201, they're just being really nice. What's really going on? Suicide is an act of an individual that the actual reasons for choosing such a final course of action are never known to anyone but that individual. Okay. So again, refer to another one of your charts. Life events linked to motivation for suicide. Suicide committed by another family member or friend. This is just the data that we've collected, and they're just putting it together. It's not saying that, this is the reason why, but they're just saying, okay, when this person did commit suicide, we're looking at, this number of people also had a family member that did. A history of physical, emotional, or sexual abuse is linked to suicide. So a person might think, I don't want to experience that trauma or that violence anymore. So asking those in-depth questions, gathering that information, and seeking out those resources for them is key. Physical dimensions. Thoughts of suicide produce many of the same biochemical changes in the body as are produced by depression. Emotional dimension. Clients are filled with feelings of ambivalence, anger, aggression, guilt, helplessness, and hopelessness. Intellectual dimension. Intense emotional suffering leads to distorted thinking and self-defeating thoughts. Remember on the other slide, the person might say, I'm just, nothing ever good is going to happen to me. Never. And it's nothing good. So it's negative. It's self-defeating. So social dimensions includes one's view of others. And then spiritual dimensions, you want to consider cultural, religion, and ethical dilemmas associated with the person's own demise. Okay, so categories of motivation. Suicide victims share two major viewpoints: deep despair, poor self-esteem, and feelings of being trapped. So that's why we want to, talk to our clients, our patients, and encourage them to not only do the medicines, but also if they have a mental illness or have a chronic disease process. We just want them to make informed decisions. We don't want to make them do anything, but we want to make sure they have enough information to make an informed decision. If this treatment, have they been just only told one treatment option for the chronic disorder that they have? So we want to encourage their client to find out, are there some other alternatives that might not be as hard on the body? There might be some combination treatments for whatever they're experiencing, so that like I said, when they see themselves, a lot of times people say, I'm not even the same person after going through that treatment. So then they begin to develop that poor self-esteem and that have that poor self-image of themselves. So a cry for help, refusal to accept diminished quality, style, or pace of life, need to affirm one's soul, relief from distress, preoccupation with suicide. Okay. So how does suicide affect family members and friends? Just think about that. It's not just that person, you know, that has committed suicide, but think about if they have children, if they have nieces and nephews, mom and dad that are still with, how would that affect them? Just think about that role. Just imagine if they were the breadwinner, or even if they weren't the breadwinner, they're the ones that directed everyone in the family in the event that a crisis did happen. They kept the family functional. And if that person is no longer there, think about that family. What would you advise a friend or family in which a suicide just took place? So in the chat, we'll just give you 2 minutes to respond to that question. So you are in the chat responding to what would you advise a friend or family. So you're talking as a nurse. And as a nurse, we're friends with our patients. We're not breaking rules or anything for them, but we do want them to know that we are human as well. We are the nurse, but still we are human. So we are responding in the chat to what would you advise a friend of the family in which a suicide just took place. Find my little timer. Put my little time on. Okay, about 35 more seconds left. Because remember, you're getting ready. You're gonna be that person that's doing the talk. You will be the nurse. And even though we have all these other people on the healthcare team, you're that central component. They're looking to you to guide the ship, so to speak, or to, at least reach out and contact others on the healthcare team if they are needed. Okay, got it. Good. I see your responses. So we want to include family members in the assessment of the suicide attempt client. They may provide some insights in the client's behavior, especially if the client is unconscious. They may can give us details of what led up to it, and they can give us some more clarity of, what was going on. Was there more than one thing, and what was going on? Suicide has a strong effect on those left behind. So it's not just that person. It is if they have children. It is the dog, the cat. It is also the mom, the parents, the neighbor, the church member. Survivor guilt. Survivors often think that they could have done something to prevent that suicide. So if we're doing like a health fair or we're doing a health summit and suicide is our topic that they give us, we want to, educate those about being proactive. And that's our little timer. Seeking out coping strategies, and so whether or not that be journaling, painting, or whatever it is. The survivors of suicide, no matter who they are, must grieve and learn to heal as well. We don't want to forget about them. So it's sort of like when a person gets hospice care, and they take care of the patient, but they also have services that they provide for the family members as well. So we have to just think about more than just that patient. And these are some theories. Psychoanalytical theory, social logic theory, and personal new biological evidence. Anxiety and depression are often the forerunners of suicidal thoughts. So it's so important that we get the clients, if they require medications, that they follow up, make those follow-up appointments before they leave. Do those depression screening questionnaires. The clients ask you why you asking all those questions. Inform them as why you're asking those questions. We're trying to determine in the event that if you're depressed, what's your next steps? We're trying to, get assistance, identify resources if needed. Okay. Today, suicide is the second leading cause of death. We just said that. That was on our earlier slide. Suicide in children is most often the result of family conflict or disruption. So remember, we were talking about the dysfunctional families. It is those that have not identified in the event that a crisis, and a crisis can be different for different people. But whenever something's going on that's disrupting the natural flow of things, what are our responses? What tools, what resources are available? If a family doesn't have that as a unit, then what's going to happen? They're going to spiral out of control. They won't be able to identify, well, I need to reach out. I need to go get my medication refill. I need to call and make that doctor's appointment to follow up. Okay. Suicide in adolescents, especially those with low self-esteem, may consider suicide as an option for solving the problems. Factors in adolescent suicide: depression, poor impulse control, emotional isolation, dysfunctional or disruptive families. They are experiencing, there's no flow. They look in the refrigerator there, as a child, they may not have had food. And so what did we do? Did the child just not get fed, or did the family seek out neighbor or food pantry? Because things can happen that, can put us in a crisis or in a mode, like I said, a storm. A person could have just lost their job, but how do we pivot? If a person doesn't have those positive coping strategies, well, hey, I can't physically go to the store and buy food, but can I get to the food pantry? Can I ask the neighbor for a meal? And so that's functional. Not saying that dysfunctional is that something's happened to a family or a person that they're dysfunctional. No, it's how we respond when something happens. Are our responses reasonable, or we just let things happen and we just go hanging in the wind? Suicide is a significant problem in adulthood. Women attempt suicide 3 times more frequently than men. Men are more successful at completing the act. Loneliness is a factor in adult suicide. Identifying what's happening in the town. The library has a book club. They're always doing something at the library, it seems like. And it's activities that you never really would think. They have things really for children. If you have a community center, that's a place that have a lot of different activities that might address people's likability. Not everybody like everything. Everybody don't want to play basketball. Everybody don't want to swim. And so, but what are some other things? Community centers, they're big at having all kinds of stuff. Piano lessons. You come and sit and you chat, you exercise together, and all those things. So that can help with that loneliness factor. Do not hesitate to ask clients if they ever think about suicide. That's on one of our little questionnaires. We have to ask that question. Suicide and older adults. As age increases, so does the rate of suicide. Sometimes it's like a person has lost their self-identity, like they were like the breadwinner, now they're retired. Well, they talk about being retired. But then after like a couple of first months, for sure by that first year, people are like, what do I do? What do I do? And so that's why you do see so many people that are retired come back to work. They don't work full time, but they do something just to keep themselves, they say, moving around and knowing what's going on is what they say. So passive suicide, that's that refusal to eat or drink or cooperate with care. Older adults tend to not communicate their intentions unless directly asked. So depends on what setting you're in. If we're supposed to ask whatever those questionnaires have certain names to them, go ahead. Like someone mentioned earlier, they have to ask those questions. Make sure that we're carrying out our tasks. So we want to pause and do another 5-minute break. We need a 5 or a 10. I'll let you all tell me. Because I need to adjust the time at the end. So what are we doing, a 5-minute or are we doing a 10? If you need a 10, just say you need a 10. It's fine. What you need. I'm only hearing one person speak. I see a 5, 5, 10, 2 5s and 1 10. So let's just do a 7-minute break. I adjust the time. So we'll see you back at 7:40. 7:40. We're just gonna do a 7-minute. So that's 3 minutes I need to put on the end. All right, see you at 7:40. All righty, let's rock and roll. Older adults tend not to communicate their intentions unless directly asked. Thus, suicidal attempts in older adults are more successful. Most older adults view timing of death in one of the following ways: God control, physician control, individual control, or controlled by the individual alone. Suicidal persons have a number of characteristics: a preoccupation with death. Don't take anything that your patients say as not important. Document whatever they're saying. A sense of isolation and withdrawal, few friends or family, distraction, and lack of humor. They often seem to be in their own world. A lack of sense of humor or even pleasure. you know, they drinking their favorite drink, but sometimes you can get it, get your little favorite drink, your Pepsi or whatever it is, and it's flat and it doesn't be, you don't get that, feeling from it, or drinking that refreshed sip of water, how you say, whatever it is, but that lack of sense of pleasure. They focus on the past. They dwell on past losses and defeats. It's like always that negative part. That isn't all of the past. And we all have some losses and some defeats, and that's just part of our journey. But we don't want to focus on that and just dwell on it and think that that's our end. Thoughts of suicide can be described by suicidal ideations, threats, gestures, behaviors, or even attempts. The last level is completed suicide, the successful attempt to end one's life. Motivation for successful suicide may be conscious or even unconscious. So we want to, of course, be documenting and don't take anything that they're saying lightly. It's all important information. Identify what are our next steps. So reporting to our supervisor, reporting to the healthcare provider, what are our next steps? So a number of activities are associated with committing suicide, making that will. That mean everyone that makes a will that they're contemplating that, but this is just some data that they pulled together. Getting the house and affairs together, unexpectedly visiting friends and family members, purchasing a gun, a holster, or rope, writing that suicide note. Preventing a suicide from occurring means saving a life. Assessment of suicide potential. You want to evaluate every client for the potential. And that's where it comes in, making sure that if you have that questionnaire that you're supposed to be asking those questions, make sure that you're completing your task as that nurse. Ask the client directly whether he or she have any thoughts. In those questionnaires, you ask directly. They have it listed out for you. Okay. When used as part of a health history, the suicide assessment will yield valuable information about the client's suicide intentions, along with numerous clues from the individual. We're asking about their substance use. Is there a plan? Have there been any attempts before? Okay. So these are some problem statements. Nursing diagnosis related to suicide. This is coming from that NANDA list. Okay. What therapeutic goals and interventions are appropriate for clients who exhibit suicidal behavior? What do you think of some therapeutic goals or intervention? We talked about in equipping them with some positive coping strategies. It doesn't mean it could mean taking your medicine, following up with your doctors, and then we're talking about, let's stay back looking at the bigger picture. They have a chronic disease process, they're just tired of dealing with the high blood pressure. Well, are you doing self blood pressure monitoring? Are you taking your medicines? Are those medicine causing side effects? Does your doctor know that they're causing side effects? Have they changed you up? And so our interventions could be having those conversations, doing an in-depth health history, asking more focused questions to help them to identify um, their next steps so that they don't lead to that despair. So that then lead to a person wanting to harm themselves. Okay. With the encouragement of advocacy of their caregivers, many suicidal clients are able to develop effective strategies for living satisfied lives. Journaling, if they're lonely, like we mentioned before, joining a group, creating their own group, starting a group. and everything. Take up garden. They can get a little side job. They don't have to do, if they're retired, they don't have to do anything strenuous. They can just go around and tend to people's flowers in the yard. They can come up with some stuff. Start a book club. Lead that. Okay, so are there any questions about that? Was chapter 27. That was our inward. We reviewed, we talked about outward focus, inward focus. And so let's move on. Let's do a Kahoot. Let's see. Let's look at the information. Just make sure we got a good understanding of it. Let's see. Let me find it here. Okay, it is loading for us. All right, go on over to www.kahoot. That's it. And let me share my screen. So if you're experiencing any connectivity issues, just please share a message and just keep logging back in. It sounds like somebody's dropping off. All right, so put in the game pin of 5111001, and at a minimum, just log in with your initials. And let's
That was me, Miss Ford. I didn't drop off. I just changed from one device to the other because one was dying.
Okay, yes, okay, great. Thank you. Bar out the way. All righty, do we have everyone in? Let's ready to Kahoot it. And start. I'm gonna mute myself because otherwise I'm gonna be trying to talk through it. So tomato, think about words that mean the same thing while thinking, intellectual. All right, so now let's transition to substance related disorders. Let me get it pulled up. Okay, getting ready to share my screen here. So of course, I always look at those objectives, and it will, especially after you look at the content, looking at the objectives can help you to determine and pick out which concepts you have a good understanding of and those that you do not. Okay. The term substances and chemicals are used interchangeably. Okay. How are substances ingested? So what are some ways you can come off mute and just say some ways that you know that substances are ingested?
Pills, like swallow them.
Say that again.
Like pills, like
Oh,
swallow.
pills. Okay, pills, got it. How are substances ingested? Is it by mouth? That's the only way that they ingest those substances.
Intravenous.
No.
Intravenous.
So intravenous, okay. What else?
Inhaling,
Got it. Inhaling, call it huffing. Got it. Eating,
injections,
injections. Yep, got it. Okay, so substances, drug of abuse or medication or a toxin. Substance use, ingestion of a chemical that affects the body. Abuse substances, chemicals that alter individuals' perception by affecting the CNS. Okay, and then we have substance drug abuse, that's excessive use of a substance. So a person can be prescribed, for example, pain medication, but they're using it outside of the reason it was prescribed. They're using it as in an excess. Okay. So habituation, the individual depends on a substance to provide pleasure or relief. You know, that's the only way. They don't take pleasure in, getting that cool drink of water or their favorite Pepsi, Coke, or whatever it is. It has to be that substance. So the example here, Mary takes Restoril every night before she goes to bed. She believes that she cannot sleep without it, even though it's prescribed to help her rest, but that Mary's thinking that's the only way that she can go to sleep. Okay. So examples of substance dependency, Alan takes 5 milligrams of Valium 3 times a day. When he occasionally omits a dose or two, he reports that he becomes shaky, anxious, nauseated, or have muscle aches. So that's that body going through those withdrawal signs and symptoms. So we do want to ask, well, if we're doing our head to toe assessment and our client is saying that they're experiencing, shakiness, well, once you get down to the medication part, well, when was the last time you took these medications? Because sometimes they'll tell you what they're on, but when was the last time you actually take it? Have you missed doses, skipped doses, forgot doses? That's actually one of the questions I think too now that we're asking everybody. Do you routinely forget to take your medicines? Or something like that. They ask. But what I'm saying is, if we ask that question, then some of the signs and symptoms we can make that connection. Well, maybe this is why they're experiencing those signs and symptoms because they were taking these meds, and now that all of a sudden they missed 2 days of it. Lori has tried to stop smoking. This is addiction. Has tried to stop smoking several times. She says that she just could not do it. Abstinence, an addicted individual is not using an addictive substance at all. They're just not using. Okay. How does chemical dependency affect individuals from different age groups? Let's think about that. Okay. The use of chemical substances occurs throughout the life cycle, from the fetus to the older adult. There are no safe drugs for pregnant women. Excessive alcohol use can result in fetal alcohol syndrome. Cocaine use. Infants exposed to cocaine in utero have problems sleeping, eating, and then have unusual levels of irritation. So it's like almost like they've ingested the cocaine as well, and it has affected their development. Children abuse substances too, but often the substances are legal and easily available. Alcohol is the one that's most frequently abused. Adolescents, sometimes they think that the children will think that that's what they need to have a good time and have fun. And so it might be easily available. And then, they're thinking that's what they need to be cool. Alcohol is the most frequent abuse drug of adolescents. Adolescents have various patterns of substance use. They may experiment with using drugs. They may use substances in social settings for relaxation or intoxication. With addiction, teens are likely to become involved in illegal activities. Because remember, with addiction, they have to have it. They have to have it. And so, in the event that they don't have the money to buy it, or the resources to obtain it, then it might lead to illegal acts of that person. Adolescents frequently succumb to peer pressure that results in drug and alcohol abuse. So, some interventions we want to teach our children is, effective coping strategies. Just say no, don't give in to the peer pressure. This has led to alcohol-free clubs, recreation facilities for teens and young adults having these uh, times that they can just, celebrate and be themselves without having the risk or feeling that alcohol might be at the party and I don't want to go because they're going to make me drink alcohol, or I feel that I have to drink the alcohol. So you see the towns and the communities having more events for children, and so that they don't have to fear of, you know, ingesting something that they don't want to ingest. Substance abuse is common in adults. 10% of adult population regularly abuse alcohol. More than 40% of all drug reactions occurs in individuals older than 65 or older. Healthcare providers should be alert to the possibility of substance abuse in older clients. Don't think just because it's, the 80, 90-year-old, if they're coming in presenting certain symptoms, we still got to ask them the same questions or same questions. Okay. Substance abuse has many costs: financial costs, human costs. Substance use and dependence cost society dearly. Many deaths attributed to falls, drownings. That person's impaired and they cannot react or respond like they need to. They're driving a vehicle, they're going out swimming, and they've ingested whatever, so they, won't respond or even realize that they're, actually gone out too far beyond the tape, the line, the flag. People with serious mental illness who are also addicted to or use chemicals are said to have a dual diagnosis. Alcohol has a depressing effect on the CNS. So we're going to see things kind of, if we're assessing them, we're going to see things high or low. We are assessing someone that has alcohol on board. Will their signs and symptoms be hyper or hypo?
Hypo.
Hypo, yes. So it has on the CNS, there's a depressing effect. It slows things down, okay? Narcotics, CNS depressant, occur naturally. We got opium, heroin. A depressant sedates the central nervous system. So it slows those things down as well. So again, I think we said we would remind our clients if they were to, prescribed, they just had a procedure done, hip replacement, they're out, rehab, and they still have a prescription for those pain meds. By then, hopefully they do know how it's going to affect them, but we still want to provide that reinforcement so they can be thinking, well, hey, I'm getting ready to go back to work, and I operate this machine that pushes down walls, or this machine that does whatever. And so we do want them to, to make an informed decision. Well, hey, do I need to take this medicine now? I don't want to lose control of this machine that I'm operating. It ends up hurting myself, my coworkers, or others. So stimulants are another group of commonly abused substances. A stimulant increases, it does the opposite, So we're going to see hypersizing symptoms. Okay, cannabis is available in several forms. Caffeine, um, cocaine, crack, certain prescription drugs, amphetamines, appetite stimulants, and Ritalin, cannabis. These increase the function of the CNS. Okay, hallucinogens. These are natural and synthetic substances that can alter one's perception of reality. So we just want to make sure we're doing that in-depth assessment. Whatever that the client is saying, if we are observing things, we want to make note of it. If they're saying, that they see, butterflies, I don't know, Ryan frogs, bats, we want to make note of that. And so, because their perception of reality might have been altered due to something they have ingested. We do know, like I said, these hallucinogens, they make people hallucinate. Okay. So chemicals of abuse, you have a whole list here. Usually, you might have even seen our patients that some wear these fentanyl patches. We have to give an account to those. You may have even administered some morphine or seen it administered. Your lower tabs and things like that, those narcotics. We have to do that count, making sure that count is correct. Don't accept those keys, and don't you get those keys away until you do that count with someone. So these are some other chemicals here, designer drugs. Okay, this is just some more listing of of drugs. Many chemicals that were developed to save lives and to ease suffering have potential for abuse. Now, who would have thought laxatives and diuretics would have made the list? Yep. So if someone is, wanting to, they have a desired weight, you can see people overusing diuretics and laxatives. They're not even prescribed any, but they're trying to, seek out who's on them so that they can take them. You'll see it. Volatile substances are chemical gases that are inhaled for their effects. Some examples are alcohol solvents, gasoline, glue, paint thinner, nicotine. So some complications is sudden death with some of these things. So we do want to make sure that we're educating our clients. You're that school nurse. We're providing that education for them. And then we want to encourage those events and things so children can just be children and not be at an event and thinking they have to ingest these things, because it could be the difference between life or death if they do inhale or ingest, chew, or smoke some of these things. So some causes of substance abuses are unknown. Biological theories, variations among ethnic groups offer genetic and biochemical explanations. They're gathering all this information, that just trying to figure out what is it, but really it's unknown. The individual, when they look at the environment, so what's in that person's surroundings that would place them at a increased risk for actually using some of these substances. They look at all of that. Okay, so we're gonna look at the stages of of addiction. Excuse me. Early stage individuals are able to use and enjoy their chosen substance. Middle stage, intoxicating episodes increase as the body attempts to compensate by adapting to the substance. Okay, tolerance develops as increasing amounts are needed. They need more, they need more. In the middle stage of addiction, how would you expect an individual to react at this point if he or she was unable? So we're in that middle stage, and this is where they are needing more of it. What about if they couldn't get it? So you have the patient that's in the ER or the urgent care. What things would you think, what would be your observation? More than likely, we have a person, they're needed more and more, but they're not able to get it. So what are some things that you think that you will be documenting that this patient is doing?
Um,
Agree.
anxiety or
Anger, aggression, different things like that, getting very short-tempered, not wanting to be around friends and family who know them very well, like seclusion, all of that.
Restlessness and agitation.
They're
Good.
tweaking.
So you want to make note of it. be proactive, having those good observation skills. It could be that's what's going on. They're needing that substance and they can't get it. Okay. Anger to the point of them being violent. Got it. Good, good, good. Then we have the late stage. Tolerance for chemical is usually quite high. The need for the substance now leads to loss of control over one's behavior. They cannot tolerate just living without it. They're just that's what's on their mind all the time. If the individual does not seek help, he or she will ultimately end up in jail or either more than likely passed away because it is like a domino effect. They can't get it, but they need it, so they start doing all these things that's going to put them at risk for someone hurting them or them hurting themselves. Individual must meet that certain criteria. The pattern of substance use must be disabling and must lead to a significant impaired function or distress. Okay. Okay, so here's some nursing diagnoses that would be appropriate for a substance abuser. We're just looking at NANDA. They're at risk for violence. As you all just said, they risk for social isolation, even sexuality pattern disturbance. They're at risk for all of those things. Okay. Guidelines for intervention. Of course, we want to do our assessment, looking at all the body systems, because if they haven't met the substance on board, we may see some hypoactive things or we may see some hyperactive things. We're going to make note of that. The three most commonly abused types of drugs are alcohol, sedative alcohol, and combination of opiate narcotics, chiefly heroin and stimulants. And so amphetamines and cocaine. So those are the ones that we're kind of seeing that people are using. But nevertheless, we're going to still provide that best care for that client. We're going to do that in-depth assessment, trying to seek out and determine what's the best plan for this for the patient. So treatments and therapies. They have all these different models out there, from the 12-step to the medical model, the psychiatric model. This is just people just gather information and people design programs or resources and they just follow the views or the guidance of one of these models. Like the 12-step, they've gathered information that says it takes these 12 steps and these are what the steps are. We're still trying to figure out what we can do. Methadone has been administered to ease the effects when someone has been using heroin and they're coming out trying to stop it. You see patients on methadone as well. And another thing is to prevent overdoses. They're equipping community members, emergency personnel, everyone, police officers and things like that with, it just left me, y'all. What are they equipping everybody with? What's the stuff that we're giving? We can administer it through an injection. Narcan. Thank you. So yeah, so you see a big push to have it available, make sure people know how to use it, administer it. And so in hopes of, saving someone. Okay. So relapse or recurrence of substance abuse and behaviors after a significant period of abstinence. Clients who have relapse feel many distressing emotions. They really do. Because I haven't seen really anybody that don't want the best for themselves, that don't want to lead productive lives and whatever that productive is. So they're really, really trying to do good, do better, be productive, but sometimes that relapse happens. And even with that, we still want to provide those positive coping mechanisms. Can't beat yourself up. Okay, what's our next steps? Okay, this happened. What are we going to do next? Let's keep, try to encourage them to press on and identify what the next, if they tried the 12-step, they may need to try a different program or whatever, but we don't want them to lose hope and give up. So these are some other nursing diagnoses that relate to the client with substance abuse problems, are based on the identified problems and what the goals are. Extra care for each client. Sometimes when they are coming in and they're going through that withdrawal process, that client may need total care. They may need someone to bathe them, feed them. If they're going through those withdrawals, it just depends on what those body systems, how that cognition is. They may not be aware of even reality. And then as days go on and they work their way through that withdrawal process, they will be more independent. They'll be able to feed themselves and things like that. But we do want to remember about safety, you all, because if they are um, going through those withdrawal processes, they are seeing things that are not there. They're looking at you, you're human, and they're thinking you a bunny rabbit. I mean, they don't have that reality base. So we want to make sure that we are keeping that in mind, keeping ourselves safe and as well as them. All right, so substance related disorders, you all are rocking. So one more Kahoot. Let's make sure we're gonna sum up substance, and then we just have interpersonal violence. We're almost there. Get it pulled up here and let you all do y'all thing. Doo-doo-doo-doo-doo. Here we go. And it's loading. It's loading. So, what time is it? So just making sure we're pushing our other time toward the end. You also, if you need to use the restroom or something, don't go and stay out and stay the rest of the time now because we're pushing our time to the end. So, we don't want you to, don't think you can't get up and go use the restroom if you need to, or tend to whatever's going on in your space now. Go ahead and do that. And come on back. All right. Let's Kahoot it. 802-2489. At least log in with your initial. You can do more than that if you like. But log in. We're looking at this information in a different way. It's repetitive, but the more you see it in different formats, you're gonna have it. Log in, log in. All righty. Do we have everyone logged in? And let's get ready to Kahoot. Shoot. Okay, we're almost there. We have just one more set of concepts and we'll wind it on down. Let me pull it up here. Okay, so we're going to look at interpersonal violence. Let me share my screen here. Be on the lookout. Dr. Buzz is going to post that her exam review session time and date. So, but that will be in the announcement section. So just make sure you're looking out for that. Make sure you go back and view our classroom recordings. Send that email if you have questions about anything. All right, so we're gonna look at violence and interpersonal violence here. Okay, violence is that intentional use of physical force. We're intending to use force or threaten against someone else or a community. Interpersonal violence is when a violent act occurs between persons. Okay, so you must consider the recipient and the offender along with the nature of the violence, the environment in which it actually occurs, the relationship between the perpetrator and the recipient. We need to think about all that. So we're thinking about the recipient and the offender. What is the nature of the violence? Is it what's some descriptive terms that they use, like brutal? Where did it happen at? Was it in their home, a place that was trusted? Was it out? A person was walking in the neighborhood, getting in the car. Was their relationship? Was this person, did they know each other? Or was it just a random act? Okay. So we do have various categories of interpersonal violence. Okay, bullying falls up under that. Okay, so physical consequences, physical injury, sexual trauma, unattended pregnancy, violence during pregnancy may have detrimental effects on the mother and the fetus. Intentional or intentional death from injury can occur in all these populations. Okay, so mental health consequences, PTSD, depression. We do want to ask those questions first. Those questionnaires that we have to ask. Seek out resources. Make sure that you have brought your social service person on board, so they can assist in identifying your case manager. They can assist in identifying resources in the area. Of course, your healthcare provider. So we have bullying. Consequences of bullying. Risk for bullies to develop antisocial behavior tied to criminal convictions and traffic violations. Victims have lasting effects. Bullying is like it's real. It is not for fake. It is a real thing, y'all. And so in the event that you're experiencing, your children, family members, whatever, we do want people to report it because it's not that they're making it up. And people can do it in different ways, like through social media and things like that. That's why I think I mentioned to you all, maybe the other class, be careful what you're sharing on these social media sites, what you're liking, because I know you're like, oh, I could just look at that stuff and I could just share it. But then if that person that initially put it out there, their intent was to cause somebody harm through bullying or whatever, then do we play a part in that? It was some movie I was watching. You all may have even seen it, where the person I think was what was the man? I don't know what it was. I think they was trying to say he was an abuser of ladies. I think they was trying to say that. And what they did was they posted it on some site. They captured him. And when the clicks or the likes or something got to a certain number, they were going to actually cause harm to the guy. I don't know. Y'all may have seen it's some mini series or something. But bullying is real. On the other side of that, people can cause harm to themselves because they are being bullied, so it is real. Interpersonal violence, infants and children in cases of sexual abuse, the person may experience post-traumatic stress syndrome, and they may also develop inappropriate coping mechanisms and sexual behavior themselves. They may even experience developmental delays if, is this happening to a person as a child. Whatever our assessments are, no assessment finding is too small or too big to make note of, to follow up, to consult and collaborate with someone that's on the healthcare team, just to make sure, that we, provide that best care. I just can't say that enough. Just can't say it enough. Okay, so social cultural factors, migration, incarceration, unemployment, undereducation, economic stress, social economic status. History may be incomplete or inconsistent with injuries observed. We do want to ask those more focused. We're gathering our information. If we identify or see injuries, we do want to ask our more focused questions just to ensure, you know, what are those marks? What are those injuries? How did they occur? And, with this, it could go to the point where a child ends up deceased because they were shaken. Person, was tired of the baby crying or whatever reason. And, they scald them with water or they use a fork or a spoon to burn them with. It's so just make sure that we're doing those in-depth assessments, you know, having the conversations. If we're supposed to be looking at the skin, make sure we look at the skin, making note of what we're seeing, measurements, and is it new, is it old. So primary prevention, education is designed to reduce the rates of violence. Education, that is usually, that is primary prevention. Anyways, we're trying to prevent something from actually even occurring. Okay. So then secondary, remember, we're trying to detect, trying to see, if there is intimate partner violence, if this person is experiencing bullying, we're trying to see. And so that hence those questionnaires that we should be doing. So collaborative interventions treat the underlying injuries. If a person has a burn, what we need to do so that skin can heal. Report the suspected violence. Doing so is a legal requirement. Remember, we are mandated reporters. Refer the victim to a safe house. Provide that emotional support. Except we may have to bring in the person of faith. Mostly all hospitals, they have someone on staff of various faiths. We may have to bring that caseworker in, social worker. We do want to consider those collaborative practice referrals, by bringing them on board. Okay. All right, so we got some questions for you. What is the term for abuse that consists of intimidation or domination toward an individual who is perceived as weak? So in the chat, just put the number 1, 2, 3, or 4. I'll give you 30 seconds. 30 seconds. Just drop 1, 2, 3, or 4 in the chat, and then you're gonna check yourself here. 30 seconds be up before I can get it pulled up here. And let's see how you did, my little timer. Okay, bullying is a form of abuse. Bullying tactics can be physical, verbal, or emotional, often through social and cyberbullying approaches. So that's why I said be careful what we're posting and sharing. All right, which term represents the victim of interpersonal violence? Just put 1, 2, 3, or 4, and give you 30 seconds. Remember, our exams are timed, so this is a test taking tip. Read through, pick out the main concept. The concept is victim of interpersonal violence. And which one of those matches that? 9 seconds left. All right, let's see how did you do. And restart and pause. Okay. The victim is considered the recipient of the violence. Okay, on what continent is the social cultural view of theology of intimate partner violence rooted in the family and society in the form of historical legacy of oppression and colonization? In the chat, 1, 2, 3, or 4. 20 seconds. We'll see how you did. And here we go. In North America, a social cultural view of the etiology of interpersonal violence is rooted in the family and society in the form of a historical legacy of oppression and colonization in North America. All right, and then we have one more Kahoot, and that should take us home to the house. How did you do? Did you get most of them correct? Looks like we had 2, 3, 4. Looks like most of you all did. All right, last one, last one. Let's toggle over. Do-do-do-do. The alarm still alarming. And here we go. It's loading. So while we're loading here, just remember, like I said, if you have a accommodations, please go ahead and submit that to all your professors, campus deans, so that we can make sure that that is whatever it says, that we comply with that. In the event that you're going to have, you think you might have late work, you need to communicate and get that prior approval. Make sure you have your IDs, your 2 devices, your chargers. All right. Kahoot it. 892-1838. Log in, and let's Kahoot it. I'm gonna bring my wheel and we're gonna use the wheel. I guess next week be our last week. I'll see if I can incorporate the wheel in. Log in, people. Let's go, let's go. And let's Kahoot it. Here we go. So I do see, I made an observation. You all answer more quicker or faster, more quicker. And it could be just the content that you know the content just that well. But I see you all do better with, you all answer more faster with the true and false. So use that if you like that format when you are, let me turn these little people off here. Hold on so you can hear me. So test taking tip. Hold on, let me turn them on off here. So what you can do after you read the question and you understand, you picked out what is this concept about? Like, what is this question about? What concept? Intimate partner violence, anxiety, or whatever it is. When you read each answer choice, say true or false to yourself. Is this true for what the question is asking you? Is this true? If it's not true, then you won't pick that answer choice. Because you rarely, I think, do you see true or false questions on these next gen tests and everything. But if that's a format that you better understand, so look at each answer choice. Is this true for what this question asking me? And if it's not, then you would not select the answer choice. So just the observation I made. You all, but it could have been you all understood that those concepts. You all may have had a stronger foundation with those concepts. Not sure, but nevertheless, that's good. So you are free to go. I will hang around for just a few more minutes. Remind you, exam is next week. Dr. Books will post the exam review. Make sure you go back through this recording because this recording covers 2 weeks, last week and this week. You can review week 1 as well, but for sure this one because we cover 2 weeks into one. Take care, be safe, and we'll see you next week.
What time is our exam at next week?
We'll push it out to